Professor P.N. Sylaja. She is a professor of neurology at Sylaja Institute of Medical Sciences, and she's one of the pioneers in stroke in India. She has published probably one of the largest series of primary CNS vasculitis from Asia and the largest from India. So let's go ahead and listen to Dr. Sylaja.
Thank you, Dr. Vishnu and Dr. Biplab. Thanks to Rohit and Padma for giving me the opportunity to give this talk today. I made it in such a way it was most useful to the residents so that they can clinically diagnose and how to go about evaluating these patients and plan the management. So coming to Dr. Deepthi had given an overview of the small vessel vasculitis, who has made my work easy with regard to there is a basic understanding of what is small vessel vasculitis. So coming to primary CNS angiitis, we know that this is a very rare disease, and even in Sri Chitra, we get mostly patients referred, and that is why we were able to have about 45 patients over a period of 10 years. So it's not very commonly we may be seeing the patient, and many of these patients are underdiagnosed too. It is a rare vasculitis which is restricted to the blood vessels of the brain and the spinal cord. The median age of onset is around 50 years in the 4th to 6th decade. So how do you diagnose them? The major problem is the diagnosis. There are a lot of conditions which can mimic primary CNS angiitis. So if you look at the Calibre's diagnostic criteria, you can see that acquired neurological dysfunction. So most of the time, the presentation will be with recurrent strokes, ischemic or hemorrhagic strokes. They can present with cognitive decline or seizures, encephalopathy, and headache is a common in about at least 50 to 70% of these patients. Next, so if you have all these features and you find that there are no other systemic features to suggest an infection, malignancy, or vasculitic systemic vasculitis, always think of this possibility and evaluate these patients. So then the next important part in the criteria is to image the vessels. So vessels, they can have classical alternating areas of stenosis and ectasia. I will come to that later. Or the patient should have a histopathological evidence of vasculitis. It is very important that you rule out neoplasia, infection, and amyloid angiopathy, that is the inflammatory amyloid angiopathy, needs to be ruled out. So further stratification has happened whereby they have been grouped into a definite diagnosis and probable diagnosis. So definite, you need a confirmation by meningocortical biopsy, and the rest of all the patients who do not have a confirmation comes in the probable CNS vasculitis. So what are the potential mimickers? So you see a patient with a classical combination of this, always rule out a systemic vasculitis. As you know, infective vasculitis, especially varicella zoster, which we may see. And these patients, we need to look for an infective cause. All the vasculitis needs to be excluded, and non-inflammatory, of which the most important differential which we find it difficult to exclude in patients is the intracranial atherosclerotic disease. RCVS, many a time the history will help you, so it's not very difficult. And then comes the malignancy group, which is a very important cause which needs to be excluded. What is the importance of confirming the diagnosis of primary CNS angiitis? Because the treatment totally differs. This is one condition which has got a very poor outcome. It's very prominent relapses. So immunosuppressants is the treatment for these patients. And not only that, we need to give the treatment for long duration, and the risk of relapse is to the rate of 20 to 40%. And in relapses, we need to consider more aggressive treatment. What are the important challenges in the diagnosis? Because it's a rare disease, we do not think of a primary CNS angiitis at the first point of time. So you need to exclude other causes, and then you consider the possibility. And the diagnostic test, as I already mentioned, many of these diagnostic tests has got low sensitivity and specificity because there are many other conditions which can produce a similar picture. And there can be a DSA normal even in biopsy-proven vasculitis. So biopsy is a very important part in the evaluation of these patients. So if you look at the classical presentation, in a stroke neurologist, most of the time we tend to see these patients when they present with ischemic of hemorrhagic stroke, younger patient who is having risk factors, has got a prominent history of headache, or presentation with associated seizures or neurobehavioral changes. When you see this combination of manifestations, you should consider the possibility of a primary CNS angiitis. This is the French series of about 52 patients which they have published in 2014. Here also you can see that the prominent symptomatology are the ones which I mentioned earlier. So this is from our own data, which we published of about 45 patients, where we looked into the initial presentation. It's not all the presentation. What was the initial presentation? If you look at, only 1/3 of them presented with an ischemic stroke presentation, and headache was not very prominent in these patients. And a cognitive decline is an important presentation in this patient. We need to look for that. And a tumor-like mass lesion is also one very important type of presentation, where they present with one-sided weakness and you see a big mass lesion in the brain. What are the diagnostic modalities? As I already mentioned, MRI, very important. MRI is always abnormal in patients with primary CNS angiitis. You need to have a digital subtraction angiography. CT angiography or MR angiography alone may not be enough in these patients. Biopsy is important. CSF study, very important to look for. It is mostly with regard to ruling out other infections and malignancies, and also it is abnormal in CNS vasculitis. So coming to the neuroimaging features in primary CNS angiitis, you can see patients having multiple infarcts. It may be acute or chronic infarcts, or it can be bleeds. This is both are our own patient. This patient with the bleed had presented as the initial presentation was with intraventricular bleed. Next is, they may see, as Dr. Deepthi has mentioned, you see multiple microbleeds in these patients, or even small cortical bleeds. Then you have these small vessel ischemic changes. Most of the time it is be grade 2 or grade 3 changes. This is one of our patient who presented with a mass lesion. DSA was negative and it turned out to be vasculitis only by doing a biopsy. Then you may see this leptomeningeal enhancement, which also gives a clue that it is a vasculitis. These are also few of our patients where vasculitis presented initially with the ACA stroke, multiple microbleeds, parenchymal enhancement, and the small vessel ischemic changes in a patient with not much of risk factors is a very important clue to suggest a small vessel vasculitis, and multiple territorial infarct. Having without much of large vessel changes, you should still suspect whether it is a small vessel vasculitis in these patients. So let us look at the angiography findings. If you look at the angiography, you can see that. So this is a classical picture, and you see in the angiography, you may see areas of narrowing and then stenosis and dilatation you may see. And then you may see these kind of changes where you may see patients having a dilatation, ectasia of the vessels, and these things should suspect, but you can get all these pictures even in patients with other conditions. Like it can happen in a RCVS, you can have a similar picture, even in intracranial atherosclerotic disease. But one important point is that in patients, if you have a combination of medium and smaller vessel involvement, always suspect the possibility of a primary CNS angiitis. It may show multiple areas of isolated occlusion also. And we had one patient where we had to do, it turned out not to be microaneurysm, it was even a macroaneurysm. And we indeed went ahead and did a clipping in this patient, and we published that case, which turned out to be biopsy positive primary CNS angiitis. So this is other features which you can see. You can see fusiform dilatation of the vessels here, and you can also see the narrowing and the thickening of these vessels. So the classical features: beaded appearance, isolated multiple areas of occlusion, luminal irregularity of the vessel. It involves mostly medium and small, but it can even involve the more larger vessels too. CSF finding, mostly what you look for is whether there is an infection. Look whether the sugar is normal or not, or sugar is low. CSF will be abnormal, but most of the time in primary CNS angiitis, it will be a pleocytosis you may see. And along with the pleocytosis, you may see protein elevation, but the sugar is usually normal in them. So mostly the CSF is done to exclude infections and malignant infiltration. We in fact had a patient with a brucella who was presented like a primary CNS angiitis, and the CSF, the only way we found out that the patient was having brucella, and the patient improved after the treatment. So it's very important to exclude infections, all the more because we are going to give aggressive immunosuppressive treatment for these patients. As far as possible, you should do a meningocortical biopsy for these patients. The biopsy is very important to rule out many of the mimickers of primary CNS angiitis. The biopsy should be an open biopsy, and you should tell the neurosurgeon there is a need to have a leptomeningeus dura and a part of the gray and white matter should be included to get a positive biopsy. And more important, if you have a patient with a cognitive decline presentation and you have a BSA normal, these patients' biopsy is likely to be more positive. Why do you get biopsy negative? Is most of the time these are all segmental involvements, so you may not pick up in the area where you have done the biopsy. Second is, if it is a larger and the medium vessels are involved, the meningeal vessels may not be very much involved and you may not get a positivity in the biopsy. So coming to the brain biopsy, these are cases from Neurology, Green Journal, where 61 patients with clinically diagnosed primary CNS angiitis were biopsied and only 1/3 of them turned out to be primary CNS angiitis. So this shows the importance of having a biopsy. Infections needs to be ruled out. Intravascular lymphoma is an important cause presentation of mimicker of primary CNS angiitis, and other infective causes needs to be ruled out in these patients. This is also another paper on biopsy. As you can see that it is important to rule out, only about 10% turned out to be primary CNS angiitis. So at least to rule out infections and other causes which are more relevant, it is important to do a biopsy in these patients. Coming to the histopathology, there are 3 histopathological patterns: the granulomatous, lymphocytic, and necrotizing. The necrotizing has the burst outcome. This is just to show the classical pictures of granulomatous vasculitis. You can see granulomatous destructive vasculitis in this patient. And this is the lymphocytic pattern with substantial thickening and lymphocytic infiltration, and the necrotizing vasculitis, which is a fibrinoid necrosis and associated with intracranial hemorrhage. So looking for any of these, because the necrotizing have the worst outcome compared to the granulomatous and the other group. So coming to the treatment, the major issue with regard to the treatment is we do not have any randomized controlled trials. It is not easy to have randomized controlled trials in this very rare disease. So most of the information and most of the expert opinions come from the case reports and the cohort studies which are available. Currently, the major cohort studies available are the French series and the Mayo Clinic series, from which you can make some conclusions with regard to the treatment in these patients. So what would be the best way to treat these patients? Definitely these patients require induction therapy with IV methylprednisolone followed by oral prednisolone, which needs to be continued, and we can start tapering after 4 to 6 weeks. When do you start on a combination of induction therapy with IV methylprednisolone and cyclophosphamide? Data is accumulating to suggest that if you give induction therapy with both, they are likely to have a better outcome, but we do not have enough evidence to suggest that. So you may, for example, you may see a minor form where you may consider IV methylprednisolone alone, but in a patient with an aggressive group, it is better to go about with giving a combination of methylprednisolone and cyclophosphamide for a period of 6 months. What are the important challenges? Are the optimal treatment regime is still not known. Minimum duration, you give the induction therapy with cyclophosphamide and steroids for a period of 6 months, and after that, slowly over the next, from 2 months onwards, you start tapering off the steroids, and after 6 months, the patient needs to be continued on a maintenance treatment. The clinical, what are the biomarkers of disease activity? There are very few. People have done MR vessel wall imaging to look at it, which is not very useful, but it would be advisable to do follow-up MRIs in these patients, because many a time the relapses may be difficult to diagnose from clinical manifestations alone. So the clinical and MR markers of disease activity need to be looked into. And more important is that all these patients are on treatment with immunosuppressive agents. You should very importantly differentiate recurrent vasculitis from CNS infection. Recently, we had one patient who had come, who was on our follow-up on treatment, was admitted in another hospital thinking that it is probably vasculitis, but when the CSF was done, there was very low sugar and it turned out to be tuberculosis. But the primary CNS angiitis was a biopsy-proven diagnosis. What I mean is that when the relapse is there, always suspect there may be an associated infection and don't think everything is primary CNS angiitis. induction, if you look at how you go about the maintenance and the treatment, there is some data to suggest that the maintenance treatment is associated with lesser relapse and better outcome. The good paper which has come out, the maintenance treatment, you can give azathioprine, or you can give mycophenolate. We usually tend to prefer mycophenolate, but there are also patients who are on azathioprine too. A treatment course is for 12 to 18 months. Even though this is what is mentioned in the literature, we were never able to stop the treatment in these patients. So the exact duration of the treatment is still not very clear. We really do not know. So this is from the paper by the Christian Partners, who is one of the main person who has done a lot of work on CNS vasculitis. If you look at this, the patients who were given maintenance treatment compared to the patients who were not given maintenance treatment, and here you can see the patients who were the relapse-free survival and the good outcome. You can see that when the patients were given maintenance treatment following the induction therapy, when they were kept on maintenance treatment for a period of 6 to 18 months, these patients had a better outcome at the last follow-up, and they tend to have fewer relapses. So there is some data to suggest that it is important to give maintenance therapy, and please do not stop the treatment after a period of 1 year once they find that the patient is doing well. What do you do in patients who are resistant to treatment? We have got, recently we have in the last more than 1.5 years, we have got 3-4 patients who had a very refractory course, and now we have got rituximab, which has been used successfully in these patients. This is from the Salvarani series, where these patients who were refractory to high-dose glucocorticoids or other immunosuppressive treatments were treated with rituximab with good outcome. Recently, we have also published on our 2 patients who had a refractory course. They initially did well with cyclophosphamide and steroids, then went on to have, this is that one of our, that same patient who had a presentation with even ring enhancing kind of lesions. Patient had multiple lesions with small vessel ischemic changes. We even did vessel wall imaging in this patient. This patient was biopsy proven, treated the patient with cyclophosphamide and steroids. Patient did well. For 1 year, the patient was okay. Again presented with a stroke while the patient was on maintenance treatment with steroids. And this is one patient who have given rituximab, after which for the last 1 year, fortunately, the patient has not had any further relapse. So this is the next option in a patient where the patient is refractory to treatment. So looking at our data also, if you look at the treatment aspects, we also initially treated them only with steroids. Later, recently, we found that it is important to keep these patients on the initial treatment itself to start cyclophosphamide. So currently, our regimen, we always tend, especially if it is biopsy proven, we keep the patient on an induction therapy with cyclophosphamide and glucocorticoids, and then go on to maintenance treatment. And very important is that the relapse is very high in these patients, and it is important to keep these patients on clinical follow-up. And I would also advise, because 2 of our patients, the clinical findings, these patients may have some mild cognitive dulling, which is never interpreted as significant by the family. It would always be better in those patients to have an MRI follow-up, where we may find significant small vessel changes. You may see silent infarcts, which may be the only clue to suggest the patient has got still disease activity. What are the factors which can predict outcome in these patients? If you have a patient who is biopsy positive, small vessel vasculitis kind of presentation with cognitive decline, this is one data which we have now analyzed. One of my resident has, Dr. Naveen has recently analyzed that data, which also shows the same finding which we are just writing up that paper. So a patient who is presenting with a cognitive decline with a small vessel vasculitis, biopsy positive, they in fact had a better outcome compared to the patients who are presenting with large multi-territorial bigger strokes, where the outcome was found to be poorer in these patients. And leptomeningeal enhancement was a good predictor of better outcome. I will end by showing a few cases and just go through the treatment algorithm. So this is a 38-year-old male who had no risk factors, recurrent strokes, mostly a ACA territory stroke. In fact, our suspicion of CNS vasculitis was not that high. CT angio showed evidence to suggest the medium vessels and the smaller vessel involvement. We did a DSA, and here we can see the classical beaded appearance and also involvement of the distal vessels, suggesting the possibility of a. So this patient was not willing for biopsy. This patient, we had a complete evaluation of all the vasculitic, systemic vasculitic workup and the CSF study. And the CSF study showed a protein elevation, but there was no pleocytosis. This patient, we did a MR vessel wall imaging. I would say MR vessel wall imaging is a very useful tool. It may not confirm the diagnosis, but it will definitely support the diagnosis of vasculitis. When your clinical diagnosis and rest of the evaluation supports the diagnosis. Here you can see that there is a enhancement with uniform thickening and enhancement of the vessels. And here you can see the enhancement of both the MC and also the base flap. So if you see a uniform circumferential contrast enhancement in multiple vessels, in multiple territories, need not be in the site where you're seeing an infarct, and you in a clinical picture where you're suspecting vasculitis, that is a very definite clue, especially if a patient is not willing for a biopsy. When a patient is well preserved, it is very difficult to convince them to have the biopsy done compared to a patient with a very bad course. This patient we treated with steroids and cyclophosphamide, 1 year follow-up, no recurrence. Currently, the patient is kept on MMF. This is another patient who presented predominantly with headache and cognitive decline. A classical picture of small vessel vasculitis. You can see enhancement, parenchymal enhancement, few microbleeds, not very significant. And this patient, all the workup was negative with regard to systemic vasculitis, infective and malignancy. CSF showed a pleocytosis. And in fact, the sugar was low in these patients. We considered strongly the possibility of an infective cause. So we went ahead and did all the CSF serology. Everything became negative. So this patient, DSA was done, the DSA was normal, and we did a biopsy, and the biopsy proved to be fibrinoid necrosis, suggesting a vasculitis. And this patient was treated with steroids and cyclophosphamide. With this patient, in fact, did very well on follow-up. And it is important to realize that even the cognitive part significantly improved in these patients. And that is a very reassuring thing for the patient too. This is one of the patient who had a very refractory course. In fact, a 55-year-old who presented with a lower limb weakness with the ACA territory stroke, had in fact multiple infarcts, even microbleeds, even a macro bleed with significant small vessel ischemic changes. And the DSA showed classical picture of vasculitis in the form of narrowing of the vessels and involvement of the different vessels. And this patient underwent a biopsy, but the biopsy was negative. But all the rest of the picture, the clinical picture, multiple territorial ischemic and hemorrhagic stroke, all the rest of the workup being negative, we definitely thought of the clinic, and we know that only about 30 to 50% of the time the biopsy is likely to be positive, and we need to have the biopsy done from the enhanced areas to get a real significantly high positivity. In this patient also, we did a vessel wall imaging, which turned out to show significant uniform contrast enhancement. And this patient, this is in fact one of the doctor's father who did very well with steroids and cyclophosphamide, and now is on follow-up treatment. I will end with the treatment algorithm. This is the treatment algorithm we made for one of the book chapters. So if you go through so we know the clinical picture of how you suspect these patients. Most important is to exclude the important mimickers. RCVS, we know thunderclap, headache, or other features will be there. Always important to rule out all systemic vasculitis, radiation, and patients to look for any malignancy is very, very important. And MRI is important to be done, and you need to do a contrast enhanced MRI and all the sequences, as has been already highlighted earlier. You need to have a diffusion, flare. Susceptibility is very, very important in these patients. You do a complete workup to rule out all the other secondary causes which we discussed. And I would also suggest in these patients, if possible, and CSF, you should look for predominantly for a low sugar, which will give you a clue to a secondary vasculitis. DSA is very, very important. Once you have a positive DSA, it is important to go ahead and do a meningocortical biopsy. Even if it is a negative DSA, if your clinical suspicion of vasculitis is strong, please go ahead and do a meningocortical biopsy in these patients. And once you have a positive biopsy, it is a definitely a CNS. Even if it is a negative biopsy, it is a probable primary CNS angiitis. And if a patient is having a positive biopsy with, you need to look at what is the type of the characteristic features in the biopsy. And in negative biopsy, we already know that skip lesions can happen, and this can also, so if the suspicion is definite, you please go ahead and do an MR vessel wall imaging in these patients to prove the diagnosis of primary CNS angiitis. The treatment is with induction therapy. I would suggest to give methylprednisolone along with cyclophosphamide in almost all the patients, unless the minor forms or where the clinical suspicion is primary CNS angiitis, you do not have a biopsy proof, you may still go ahead with the steroid alone initially. Maintenance treatment is very, very important in these patients, and continue the maintenance treatment with good MRI follow-up to look for the markers of disease activity. And if these patients are refractory, go ahead and we should give rituximab in these patients. So to conclude, primary CNS angiitis is a relatively rare disease. Early recognition with a high index of suspicion is very important. Confirmation should be with the DSA and meningocortical biopsy. Early treatment is very, very important, and vessel wall imaging may support the diagnosis of primary CNS angiitis. Thank you.
Thank you, ma'am. That was a wonderful summary of primary CNS vasculitis. I hope all the residents would have learned a lot from the CNS vasculitis, the data that you have shown. I have a few questions in the chat box also. So first question was, in workup for infectious causes, what are the investigations which you do other than from the routine tests that you have mentioned? What extent you will go to rule out infections in CSF? That's
Okay.
what we want to add.
Yes. So we usually, what we are doing is looking for tuberculous and fungal are the usual ones. But in the brucella, which I mentioned, this was one patient who came from the Gulf. So I think depending upon the situation from which you are suspecting, you may go ahead and evaluate further. But if the patient's sugar is not low, I won't be very, very extensive in evaluating for a patient. But if the sugar is also low, I think you should go behind and look specifically. And malignancy is one thing we should definitely look for. I think malignant cells you should look for, and if you have a suspicion, you should again reevaluate these patients.
And to the follow up on that, how often do you do a repeat CSF on every relapse, or what is your take on doing a CSF? For example, a biopsy proven case, they comes with a recurrent relapse and not responding to treatment. You do a CSF on every relapse. What is your take on that?
So I think we do not have any definite guidelines on that. If you look at the guidelines or whatever the expert opinion from the series, it is mostly telling about doing MRI at 3 months or 6 months, depending upon the severity of the disease. What we follow is we do not do routinely CSF studies in this patient. But if you have a suspicion where very rapidly the patient had declined and you have some features to suggest a probable underlying infection, I think we should do a CSF study, because one point we need to understand is that we have even had mortality not because of primary CNS angiitis, but because of infection and sepsis. So I think it's a clinical suspicion. There is no definite guideline. But if you find the patient has presented with a stroke, and the recent 2 rituximab patients, both of them had initial scan showing even an improvement of the small vessel ischemic changes. And when they came on follow-up, we found that there is a significant increase in the white matter changes with you are seeing a lacunar infarct. But at the same time, you may see another patient, you evaluate completely, you find that the MRI is not that abnormal, but the patient has worsened and the patient is not doing well. Please rule out an infection in those patients.
So one more last question that we'll take, maybe somebody has asked on what is the dose and regimen of rituximab that you follow for primary CNS vasculitis?
So for both our patients, we gave 375 milligram per meter square for the weekly for 4 weeks, and then followed them at 6 months. And just like there is no definite guideline separate for primary CNS angiitis. You follow the one which we follow for all the autoimmune and the other diseases.
So thank you, madam. I think we run the AIMS CNS vasculitis registry. Our data is also coming up soon.
Okay.
So let's see.
Good.
Thank you, ma'am. Thank you for